it's about 25 minutes talk and then 10 minutes questions, right?
Yeah, absolutely, sir. So, friends, we are delighted and honored to have with us Professor Giacomo Bellani, sir. So, sir is a world-renowned leader in intensive care, professor of anesthesia and critical care medicine at the University of Trento, and head of anesthesia and intensive care at Santa Chiara Hospital in Trento, Italy. He was a co-principal investigator of the lung safe study with over 400 peer-reviewed articles and a holder of multiple patents. Professor Bellani has over 30,000 citations and a Google Scholar H index of 84, specializing in respiratory physiology, PEEP titration, EIT, and he's a former chairman of the ARF section of European Society of Intensive Care Medicine. He continues to shape research in pulmonary and critical care, and it is really a pleasure and a great honor for us to have him on our forum. And he shall be speaking on a very important topic: how I use pressure support ventilation.
Thank you. Thank you so much, Dr. Tapesh, for the invitation and good evening, everybody. I understand it's now evening in India. Here it's almost afternoon. Thank you so much for the opportunity to be here and present and share some of our more or less recent findings on the topic of pressure support ventilation. Could you confirm that you see my screen, please?
Absolutely, very clear, loud and clear, sir. Everything is good. Please go ahead.
Okay. So let's move. Pressure support ventilation is very frequently used, as we will see, and normally it's considered to be as a rather simple technique. And in fact, on one hand, it is quite simple. We have only a few settings, but on the other hand, the interaction between patient and ventilator during pressure support might not be as easy and as straightforward as we could sometimes consider. Let me see if I can, okay, move my slides. And these are my conflicts of interest, which are not specifically relevant from the present talk. Okay, so if we consider the trajectory of the ventilated patients, we have different phases. We have sometimes we start with a non-invasive ventilation, and then patients who fail will need some intubation and some forms of conventional controlled mechanical ventilation. And as I highlighted here, there is a big interest in the literature in those phases: NIV, intubation, controlled mechanical ventilation. And then there is a whole field of the literature which is focused on the weaning and on the separation from the mechanical ventilation. But quite curiously, whatever happens in between is not that it's not that well studied and documented in the literature. And especially, I think there are phases in which we often use pressure support ventilation. Now I am not so much longer directly involved in the management of the patient, but I used to be very much. So I use pressure support a lot. And these phases are the early switch from controlled to assisted ventilation. And then later on, the phases in which during the attempt to separate the patient from the ventilator, the patient does not pass an SBT or is difficult to wean, and we have to reinstitute some forms of assisted ventilation. In these phases, pressure support ventilation is frequently used, and rightly so, but there are some nuances which we have to take into account. First, this is a finding that we have documented with a study I performed at the time I was working in Monza, and but then other groups have also documented. So the fact that a failed switch from controlled to assisted ventilation is associated with a worse outcome. And of course, this is an observational finding in the COVID era, and so there might also be some bias, because the more severe patients are also the patients who are more likely to fail and to die. But even after correcting for a number of possible confounder, we found, and other investigators, as I mentioned, replied the same finding, that a failed switch from controlled to assisted ventilation was associated with the worst outcome. So this period is very delicate, and how we set pressure support ventilation could be extremely important. We also have to consider the fact that, as I mentioned, the incidence of use of pressure support ventilation is extremely frequent. This is a study we performed. We will see it also later on, a prospective observational study in 16 centers from 9 countries, from Europe, North America, South America, Asia, and pressure support ventilation was used in the vast majority of patients, still with a moderate degree of hypoxemia, being switched to from controlled to assisted ventilation. So again, this reinforces the importance that this ventilatory mode, which was initially described only for, let's say, winning phases, is acquiring also in the more acute phases of the of the patient's disease. So let me explain you a few words on how pressure support ventilation work. It's not like a very basic talk, the trigger, cycling off, cycling, because all those I give for granted. It will be a sort of a little bit more sophisticated of a description of pressure support ventilation and how it works. So let's consider what is the relationship between the effort in terms of the actual pressure that the patient inputs in the system and the tidal volume that is generated. In healthy unassisted subjects, there is a almost linear relationship. Is not exactly linear, but for the sake of simplicity, so that we have a given target tidal volume, we generate the effort needed to get that tidal volume, and if we need to increase or decrease our tidal volume, we are able to do so by just changing the effort that we put in the breath. Now, we can also consider what happens to our patients. For example, what happens to a patient who has abnormalities in the respiratory mechanics, for example, whose lungs become stiff or whose resistance increase. And in these patients, we see that there is a decrease in the slope linking the effort and the tidal volume, in that the patient needs to generate a greater effort to stay on the same target tidal volume, or if he or she generates the same effort as before, the tidal volume is reduced. So we need to support this patient for him or her to achieve the target tidal volume. There is also another condition. For example, imagine a weak patient, a patient with a Guillain-Barré disease is a classical example in which respiratory mechanics properties are not altered, but the patient is weak. So in this case, the unassisted breath leads to, again, a lower tidal volume, because for as much as effort the patient tries to exert, to generate, this will be lower than what is required to achieve the target tidal volume. And of course, there are also combinations. For example, let's think about a patient who is in a winning failure condition. There will be a combination of both weakness and reduced capability of generating effort. Now, what do we do with pressure support ventilation? And maybe you find this first part of the talk a little bit theoretical, if you wish, but I believe it's very important to know the basic principle of how a system works in order to master how to set it. So pressure support ventilation adds a constant amount of pressure to the effort that the patient generates, which is constant irrespective of what is the effort of the patient, what are the respiratory mechanics, of the patient, it's irrespective of everything. As far as the patient triggers the ventilator, he or she will get some extra pressure on top of what he or she is generating. Uh, so that if an healthy subject we breathes on pressure support, this leads to a higher to a less effort to achieve the same tidal volume. Sorry, just a second. Okay. We require less effort to achieve the same target tidal volume. It's important to keep in mind one very simple concept. Again, I don't want to make it too technical, but I believe it's very important to understand how actually the ventilator works. So the ventilator acts on the flow, and so when we put the ventilator in a pressure controlled mode or pressure targeted mode as pressure support ventilation, we have to keep in mind that still the only physical entity on which the ventilator acts is the flow. And so I always make this joke that if you tell an orthopedic that the patient is connected to a ventilator, most likely this is what our friend think. I don't know if the relationship with orthopedics is the same in Italy as in India, but normally we make a bit fun of them. Anyway, but this emphasizes one concept that the ventilator is just a blower. It's an air blower, okay? And why is this important? Because if we take this tracing, we can observe two very different breaths, okay, still with the same mechanical support. On the left, the patient barely triggered the ventilator. You see the electrical activity of the diaphragm in the bottom line. So the patient triggers the ventilator, and the ventilator increases airway pressure. And to increase airway pressure, the ventilator has to deliver a given flow, which is fairly decelerated, as in pressure control. If the patient takes another breath, which is now very active, and the patient is putting pressure into the system to generate the tidal volume, this requires that the ventilator delivers a greater flow to chase after the effort of the patient. Is it as if you are pushing a car whose battery is dead? If you start, if the engine kicks in, you have to run faster. And so you see that again, to achieve the target, which is the inspiratory pressure, the ventilator has to continuously check the flow and update the flow to reach the target. And on this principle is based the concept of the flow index described by an Italian group, which in analogy to the stress index, by looking at the shape of the flow, calculates or at least estimates the effort of the patient. Now let's go back to our patients and see what happens if we apply pressure support ventilation to a patient with impaired mechanics. We set a level of pressure support and the patient will receive, as mentioned, a given amount of pressure for each breath. So despite the respiratory system is stiffer, the combination of the effort of the patient and the support from the ventilator allow to reach the target. If the patient is weak, same situation, we shift the curve upwards, and there is again the possibility that by combining the patient effort and the ventilator support, we achieve the same target tidal volume. Now, this, as I said, it's not just a theoretical framework, but it has some very important implications at the bedside. First one is that in pressure support ventilation, there is a minimum tidal volume that the patient will receive no matter what, because the support of the patient of the ventilator is always constant, is always the same. So as far as the patient triggers the vent, he or she will receive some pressure, and this will lead to a generation of a given tidal volume. So there is a minimum tidal volume, which roughly speaking is not equal but very closely related to the product of pressure support times compliance of the respiratory system. Because at the end of the day, it's almost as a pressure control in which the decelerated flow leads to an equilibration of plateau, peak inspiratory pressure, and alveolar pressure. And so you get a minimum tidal volume. Sorry, keeping an eye on my watch here. And the higher the compliance or the higher the pressure support, the higher is the minimum tidal volume. The second, so this is very important, for example, when we decide to perform an SBT and we use pressure support 7 centimeters of water, the minimum tidal volume depends heavily on compliance. And so with a compliance of, let's say, 50, almost normal for a ventilated patient, only by triggering the ventilator, the patient will receive a tidal volume of 350 ml, which is not negligible. So, first implication, there's a minimum tidal volume below which the patient will never go. And this is extremely important, as we will see later on in the phases of over assistance. The second implication is that the variability of the tidal volume is very limited because the patient can change what he or she does, but cannot change what the ventilator does. So the sum of the two pressures is what determines the final tidal volume. And if the pressure coming from the ventilator is always constant, then the possibility for the patient to change the tidal volume is very limited, as we see here. Proportional modes allow instead, and we don't have time to talk about that, but maybe in one of the next editions I will be able to and speak about this. Proportional modes allow to a much greater variability of the tidal volume. Um, I'll skip this for the sake of time, but the concept basically shows you that even if the patient changes the effort, the change in tidal volume size during pressure support ventilation is extremely limited. So this is what I described so far is what the ventilator does, okay? And what does the patient do? Because at the end of the day, the behavior of pressure support ventilation depends on the combinations of the two. And what the patient does is to add, what the patients do is to add an extra pressure to the one we see on the ventilator. An extra pressure, and I always use the iceberg metaphor, but at some point I will have to drop it because I showed it too many times. The pressure is hidden in the patient generates is hidden within the patient chest, and it sums to the ventilator pressure to determine the final effect in terms of lung distending pressure, in terms of tidal volume, in terms of everything. So we are easily able to modulate the visible part of the iceberg. We just change the ventilator knob, but it's much more difficult to modulate the hidden part of the iceberg. But before thinking of modulating this, going back to my title, how I use pressure support, I always want to know what is the global pressure which is applied to the respiratory system, not just what the ventilator is doing, but what the patient is also doing. And in order to do this, we have some very simple tools. No need for esophageal pressure, which, don't get me wrong, it's a nice to have if possible, but it's not necessary in intubated patient. And the first and very simple, the most simple tool is pushing expiratory and inspiratory hold. The inspiratory hold freezes the respiratory system after the patient has taken a breath and the patient is getting ready to exhale. So on the left and on the right, we have the same patients in two different moments with, as you see, very different levels of assistance. But if we push the inspiratory hold button, after the patient has taken his or her breath, he's getting ready to exhale. And so we see a global pressure, in this case 14 centimeters of water, which is exactly the same between those two conditions. But on the left, most of this pressure was being generated by the ventilator. On the right, most of this pressure is generated by the patient. But we only notice this if we push the inspiratory hold button. And trust me, during spontaneous breathing, the plateau pressure may be and often will be higher than peak pressure, because by peak pressure you only see what the ventilator does. By plateau pressure, you see the combination of the effort of patient and ventilator. Sometimes the patient is not relaxing the muscles, and you don't see, as on the left hand side, a clear neat flat plateau, but you see some increasing effort coming into the system by the fact that the patient is reacting to the closure of the valve and wants to exhale. So how we put this in the clinical practice? I show you an example. The same, well, this is a mechanical example, but it can be seen in the clinical practice. Um, so on the left, a patient with a pressure support of 13, and both, and same on the right. But on the right, the tidal volume is much higher. Now, if this was controlled mechanical ventilation, we would be happy, I should say. We would think that the respiratory mechanics of the patient has improved. But this is assisted ventilation, okay? So we cannot just forget about the patient component. We need to take that into account. And in order to do that, we had push inspiratory hold. Plateau, 15 centimeters of water, 9 o'clock in the morning, and at noontime, the plateau is now 22. So the driving pressure is much higher, even higher than what the tidal volume would justify. In other words, if we calculate the ratio of tidal volume to driving pressure, we notice that compliance has dropped. So you see, this is a very important information at the bedside, in that it allows us to disentangle what is the ventilator doing, what is the patient doing, and how the sum of the two reflect on respiratory mechanics of the patient. I am a little bit late, but I would just like to mention that this driving pressure measured by this technique has a tight association with outcome during assisted ventilation, sorry, whereas if we just look at the peak airway pressure, which in control ventilation has a strong association with outcome, there is no correlation, because in assisted ventilation, again, we should take into account also what the patient is doing, not just the ventilator. So I'll skip this for the sake of time, and I would like to finally, in the last 5 minutes, 7 minutes of my talk, to show how these two components interact, how the patient and the ventilator interact. So when I approach pressure support ventilation, I always take a look, of course, at the global situation, if the tidal volume is within protective boundaries, if respiratory rate is within protective boundaries. This goes for granted, but I always want to know what is the effort that the patient is putting into the system. And why this is important? It is important because it allows us to understand what is the adequacy of the level of assistance we are providing to the patient. I'll try to explain with this example. So, this is a very simple study, very simple design, because things things that are too complex don't work for me. So this is just a decremental pressure support trial, 12 centimeters of water overall. As you see clearly, the peak inspiratory pressure drops. This is well expected. But what is maybe less expected is the fact that the patient with the green bar puts back into the system exactly the amount of pressure we are removing with the pressure support. And so, in other words, the patient wants to stay on a target tidal volume and stays there irrespective of how much we are helping him or her. Because, and this is sometimes good, if I can use this expression, because we would like to wean the patient and make sure that what we are the decrease in assistance is compensated by the patient effort. But sometimes it's not desirable because the driving pressure is too high. We aim to decrease it, but we decrease the pressure on the ventilator and the patient puts it back because wants to stay on a given target tidal volume. Not all the patients behave in this way. On the left, you see an example of a so-called active pattern patient in which the decrease in ventilatory assistance is coupled by an increase of the effort of the patient so that tidal volume stays more or less constant. On the right, you see a patient who is quasi-passive. What does it mean? It means that irrespective of the effort of, sorry, the patient here is just triggering the ventilator. And so when we decrease the level of assistance, the tidal volume goes down and down and down. And we have described the fact that, sorry, uh, when the pressure support level is such that PMI is abolished, in other way, we don't see any extra pressure when the patient releases the muscles, then this leads to an increase in tidal volume, which means over assistance. And so the point is, when we set pressure support, we need to know how much effort the patient is generating and whether the amount of support we are providing is adequate to what the patient wants. Because as a last slide, I would like to mention this this conceptual model which we have described with my fellow Mattia Docci, in which we observe an area of adequate assistance in which we modulate, we change the pressure support, and the patient remains on the target tidal volume because the patient is able to increase or decrease the P mass. If we over assist the patient, he or she will just trigger the ventilator. And so the tidal volume goes up and up and up. And if we under assist the patient is not able to cope with the decrease in ventilatory assistance. And so the tidal volume will go down. So these are just hypotheses, and we have a number of questions on these, but I hope we will be able in the future to work further on these model and have some findings to translate this into clinical practice. With this, I'm pleased to let you know that I've put my talks in a book, and we made a special edition for India due to some restraints in Amazon, and so the ebook is available, and I hope you might enjoy it. Thank you very much, and I'll be happy to take questions. I hope I did not talk too long.
Oh, wonderful, sir. That was really very, very exciting and very interesting and very educative. Thank you so much for an exhilarating talk. And very nice to know that we have this book available in India now. So it's lectures on respiratory failure and mechanical ventilation, sir?
Yes, yes.
I think earlier also there was a book on mechanical ventilation written by you some few years back.
Yes, yes, that was from Springer. That was from Springer, and there were many other authors. That was more a proper textbook. This is a little bit more, lectures transcribed. So for the good and for the bad, it's a little bit more informal, if you wish.
So this is by single authors or by yourself alone, or there are the collection of
This is
authors?
by myself alone.
Oh, great. So great. We'll have a look, sir, and we'll learn from it. So
Thank you.
I request the audience, if they have any questions, please put them up. Sir is a global expert on pressure support ventilation. You will not get a better chance to put up your questions on pressure support ventilation and maybe related ventilatory issues. We'll wait for a couple of minutes. Meanwhile, sir, I can just put up a couple of points. So, sir, what do you think are the mistakes or the errors young intensivists, who are not so trained, make in using pressure support ventilation?
Can you repeat the question, sorry?
Yeah, so my question is, sir, what do you think are the mistakes or the errors that young intensivists who are not so much experienced for early in their career make in using this particular mode, pressure support
Yeah.
ventilation?
No, I think it's an excellent question. So first is I believe that sometimes one error, not specific error or something, an area of improvement. Let's put it this way, not specifically related to pressure support, but to, let's say, assisted ventilation in general. Is, as I mentioned, that sometimes we spend a lot of effort to treat the very acute phases of the patient, protective ventilation, high PEEP, and like prone position, even ECMO. And then after we are in a safer area of PF, we let the patient breathe and see, okay, it will be fine. Let's think about weaning. And this is a very delicate phase. And if we don't pay attention to that, we can go back to square one because of patient self-inflicted lung injury. So the first, I would say, caution I would increase is that this is a very delicate phase, and we should really pay attention to it. And the second point I believe is just to uh, sometimes to think that as the peak inspiratory pressure on the ventilator is safe, let's say we have a PEEP of 10 and a pressure support of 12, so apparent driving pressure is 12, and plateau, sorry, and peak pressure is 22, is the lack of the measurement of the driving pressure by either the method I showed you and or by the POCC, which is the other technique that has been described by Bertoni, and I had to skip for the sake of time. So the point is, the second possible mistake is to neglect the fact that the overall pressure applied to the respiratory system is high, and sometimes we need to be just to admit the fact that the patient is not ready for the switch, and we need to go back to controlled mechanical ventilation. And this is not a failure, but if we are very stubborn in keeping the patient on in pressure support in assisted ventilation, because we really need to win this patient, we might lose a week. And sometimes the third mistake can be to be too stubborn and keeping the patient in assisted mode, whereas switching earlier to control ventilation, maybe wait 24, 48 hours, give some negative fluid balance, improve respiratory mechanics, could then lead to a success of the switch.
Oh, great, sir. Thank you for the wonderful answer, sir. And once again, anyone from the audience, any comments, any questions? Otherwise, we'll close the session. So, as I can see, sir, chat box is okay. There are no questions. So, Professor Bellani, sir, many, many thanks for this exhilarating talk and being on a symposium and we hope to have you with us again on our educational programs. Thank you very much, sir.
Sure, sure. It will be my pleasure. Have a nice
Bye bye, sir. Bye
week,
bye.
everybody.
Bye bye,
Bye
sir.
bye.